All right, this is a slide set that I've done with a Ketoclan group before, and so some of you may have seen it, some of you may not have. We'll see as people join in here. Feel free to ask questions as I go along here. The whole point of this is to enjoy your self and learn. Hopefully, this is not death by PowerPoint, um, and you'll enjoy it. But if it is death by PowerPoint, you're welcome to log off. Or just don't die. But we'll join in. For those of you who were here last week, any questions or concerns about what we talked about before? If not, then we'll dive right in and get moving. Let me make sure everyone's able to talk if they want to, and we'll go from there. So this is one of my favorite topics is male hormones, is talking about testosterone and how a ketogenic diet affects it. And so we'll talk about the various hormones and the six ways that men need to focus on to be able to maintain their testosterone and function and control their weight and their hormone levels. We'll dive into this here. Like I said, if you have questions, ask away. I've tried to unmute everyone, so if you want to, or if allow you to talk. So if you want to pop in, unmute yourself, and then talk. If there will, I say, mute yourself if you've got conversation or sound in the background, and we'll go from there. All right, I opened this up to my newsletter group outside the Keto Clan group. So some of you may be new or have never been here. Some of you may have popped in on the other ones that we opened up. I do about 19 different presentations. This is a popular one, and so I thought I would open it up because a number of my Keto Clan group members are female, and they've got husbands that have had questions about testosterone. So I'm opening this up. I'm going to try to save this one so it's available on the website, and you can watch it later if you'd like to, and we'll go from there. We'll dive in. Basically, Oliver Wendell Holmes, who is a surgeon, basically said that a mind stretched by new experience never goes back to its old dimensions. And so hopefully I'm going to share with you some thoughts and some statistics and some factors that will change the way your perception is about hormones, and specifically male hormones, and what they can do and what they do. And we'll go from there. Anyway, some of you have seen these statistics. Back in 1991, they did an 8-year study on the Women's Health Initiative, and this is a bunch of nurses. They did they used a low-fat and a control group, and they used I think almost 50,000 nurses. And with this low-fat group versus a control group, they compared, okay, does the low-fat group lose weight? Well, over this 8 years, they lost a whopping almost a pound. But they claim it was a wonderful, successful study. Oops, I went back the wrong way. Sorry, I'm rolling my scroll back the wrong way. And so the sad thing is they only lost a pound. The multiple risk factor intervention trial, I think I shared these in another slide set before. This is a group of almost 13,000 men. They studied them for 7 years. They were all placed on a low-fat diet. These were men at risk for heart disease, or coronary artery disease is what CAD stands for. And there was a 100% failure in the capacity to reduce heart disease. They were not successful. They didn't reduce weight either, and so that's a challenge. So then we've got now these are studies that if a drug rep comes into me, they're going to quote these studies as to how successful they were. And what I want you to see is that they were not successful. This 13,000 group of men placed on a low-fat diet had no decrease in heart disease and no decrease in weight. Then there's the look ahead study, and this is often quoted frequently. It's the newest study. This was a study of about 5,100 men. It was done in 2000. It was supposed to last for 13 years. They stopped it early because it failed. It wasn't working. This was very intense calorie restriction. They lowered the calories in these men between 1,200 to 800 calories, 1,200 to 1,800 calories per day. And they gave them intensive dietary instruction. They did not lose any weight. Well, let me rephrase this. They lost 6% of their body weight, but that included muscle mass. And usually it's about 3% weight and 3% muscle. But they didn't live longer. It didn't reduce the heart disease. But they claimed it was a successful study in that regard. essentially, this is 67,000 people over 46 years that were studied cutting their calories out. And you can see that it was not successful when it comes to reduction in heart disease or reduction in weight. But yet we still persist in telling people to eat less calories. But that's not what the studies show. So I just wanted to go and just see here how unsuccessful that was. And the reason is there's two models that many doctors look at. Most doctors look at an energy balance model where it's calories in, calories out, exercise more, eat less, and they push this. What they've shown is you may lose some fat, but by the 2-year mark, your body resets itself because of hormones. The hormone model shows that there's every type of food you eat, whether it's carbohydrates or fat or protein, has a hormonal response to your body. And your body is given a signal to do something with those hormones. And the hormone model is the only one that accounts for metabolic syndrome. The calorie in, calorie out model doesn't do that. 80% of individuals can't maintain weight over 2 years. That's the energy balance model, but it really is hormonal. That's the concern. So we're going to look at hormones today, specifically testosterone. And what I want, and this is the same flow. This is the same model that occurs in both men and women. It's just that men have more testosterone, less progesterone. Women have more progesterone and less testosterone. Men have about a fifth to a tenth of the estradiol levels that women do, and that's what makes men and women different. But the signaling of the steroid pathway is often the same. So your body takes cholesterol, and all these hormones, the three that are essential are progesterone, testosterone, and the estrogens. And there are 3 forms of estrogen. A lot of doctors don't even know that, or don't talk about that, I should say. And then in addition, there are stress response hormones like DHEA and cortisol. And then we also use these same hormones to help the kidneys function with aldosterone and the mineralocorticoids. What's essential to know is if you've cut cholesterol out of your diet, you're not going to make these hormones effectively, and you'll see fatigue. You'll see a whole slew of diseases arise. If you look at what happens if you cut out your salt and you get dehydrated and you lower your blood pressure too low, it actually increases the shift of the hormones into cortisol. So these 3 signals tell your body you're stressed, and you make more cortisol because these signals are driven, and you get an increased flux of the cholesterol into cortisol as a stress response. We see an additional, if you have stress or you have lack of sleep, it has the same flux, stimulates the function and production of cortisol because it's a stress hormone. Cortisol raises your sugar and causes weight gain. So that's a concern in that regard. So let's look at the modern male fatigue that I see over and over in the office every day. But that's been getting worse over 25 years and I've been in practice. This is an interesting, I'm going to show you some interesting statistics, and we're going to look to see, does hormone play a role in this? What, I'm sure there are multiple other factors that play a role in these statistics, but I'm convinced that hormones play a big deal. So women are more likely now than men to graduate from high school. In 2020, only 41% of undergraduates at community college and 4-year colleges were men. That's significant. Young men are falling to the very bottom of the income ladder. In 1975, 25% of men between the ages of 25 and 34 made less than $30,000 per year. In 2016, 41% of men between 25 and 34 had incomes less than $30,000. And the data last year shows that 40 to 50% of men between the ages of 25 to 34 still have incomes less than $30,000 a year. When you have an income less than $30,000 a year, that's the poverty level. That's currently standard poverty level. And so these all came from the census information and the studies on the census there. That's significant. So a lot of men are underperforming. And as of this year and last year, 50% of our 30-year-olds are in poverty. That's significant. It's a problem. And I see it in my office every day. In female college students have a higher grade point average than men. They're more likely to graduate within 4 years. Among young adults, 25 to 29, 35% of women and 27% of men possess a bachelor's degree. And this gap has gotten bigger over the last decade. And now, as of 2024, 47% of women and 37% of men possess a bachelor's degree. There's a 10% difference there between men and women. That's dramatic. And there's multiple reasons for this, but I won't dive into them all. But what I want to show you is that hormones play a role. women are 60% more likely than men to earn a bachelor's degree by the time they're 23. That's huge, huge. The first time in history, more women than men are earning advanced degrees in the 25 to 29 age group. 9% are women, 6% are men. Men either held a master's or professional degree such as law or medicine. Nearly 6 out of 10 adults who hold any advanced degree between the ages of 25 and 29 are actually women. Now that's great for women, and I'm not discounting that, but there's been a significant decrease in the number of men that are actually having success in their vocation or in their education. So significant. Now, most men lost 3/4 or 75% of the 8 million jobs that occurred during the recession in 2009, 2009. For the first time in history, there are now more women in the workforce than men. Now, some of you may say, that's fine, that's great. But the question is why? Why is this shifting happening? And what may be occurring? In 2022, among the young adults, ages 18 to 24, 46% of men still live at home with their parents. That's dramatically different than the 1970s or the 60s. And 20% of men ages 22 to 34 still live at home with their parents, an increase of 100% in the last 20 years. That's profound. And I think that's actually really scary for the future of our generations. Now, are these social changes due to general male testosterone decline, or in our nation, or are there other things? What we know is as that we gain weight more, we have the aromatase converts testosterone into estrogen. And so there's a lot of men that I see in my office that have a number of feminizing characteristics in their 20s and 30s. That's significant. For some people, they may say, oh, well, that's fine. For other people, women go, no, I'm not interested in that. So that's a problem. And I'll make sure I unlock the. Any questions about that in those things? You may have questions, you may not. I'll make sure everybody has the capacity to talk. David, you raised your hand. Was there a question?
Yeah, just not to get off track here, but your analysis about advanced degrees and bachelor's degrees kind of discounts how well the skilled trades are paying right now, and you see a lot more men in skilled trades than you see women.
Yes, you do, and I didn't include the skilled trade side in there because those are significant. Yeah, what I was trying to show is, if is the educational side of things and the professional side of things that's been declining
Yeah,
significantly.
well, but I mean that doesn't necessarily mean it's a crisis for men. They're earning more without the student loans involved.
Yeah.
One more thing, let me add in
Yeah.
terms of uh, living at home. I lived for several years in Brazil, and it's very common there for both men and women to live with their parents until they get married.
Hmm.
Uh, and then they still hang around the house, like coming home for lunch every day. Uh, I'm not sure staying at home is necessarily a bad thing from a society standpoint.
Not necessarily. What I was saying is there's a significant change from what it used to be in 1970 to today. So that's the difference. But I appreciate your comments and your insight into that.
Thank you.
Yeah, those are all things we need to weigh. And so I realize it's kind of it's a very broad component that has a huge number of involvement there. I just wanted to see that there is a significant change with what I see. And I see it in my office with these 20 and 30-year-olds that are walking into my office. Many of them are still living at home. Many of them don't have jobs. Many of them, they spend, I'm shocked at how many of them spend a significant amount of time in the basement playing video games. And part of the question is, why is that happening? So we'll move on here and dive into it. One of the things that's interesting is if you look at if you're a man and you look at it happens in women too, the higher ring to index finger ratio. So if your second finger is bigger than your fourth finger, it creates a ratio. And the higher that ratio is, the greater testosterone exposure in the uterus you can see. So this is one way to if you look at a hand as we're doing an examination, if I see someone whose fourth finger is notably higher than their second finger, I know that their mother had a much lower testosterone level and exposure while they were in the prenatal period. Just an interesting examination finding. See, now one of the issues that may play a role here is this: if you have exhaustive exercise without adequate recovery, that lowers your testosterone. Many women are heavily focused on exercise, and they don't often get enough sleep or enough recovery. That plays a role. A large caloric restriction leads to a larger testosterone reduction. In fact, you'll see if you calorie restrict less than 1,500 calories per day, and you do that for 7 to 14 days, your testosterone will drop by 50% in both men and women. And that's a significant factor. A low fat, high fiber diet or a vegetarian vegan diet, you'll see a decrease in total and free testosterone by 18% within 7 days with those diets. So let's look at the andropause, or what this essentially means. Now, this is a controversial subject, and it has been for a number of years, because the diagnosis isn't really straightforward. And the reason is that there's been a shift in testosterone ranges of normal. And so there's been argument about who's actually has andropause or who has low testosterone and who should be treated. The lower limit has shifted. It's kind of arbitrary, and there's no registry of patients that shows this. And the symptoms are somewhat vague, and we'll go into that. I won't go into the validation systems that they use, but we'll look at how there isn't a single level of hypogonadism that allows us to make this diagnosis of low testosterone, and I'll show you why. So the two opposing views is, if we see low testosterone, should we treat it? Half the docs will say yes, it's worthwhile. It improves metabolic outcomes. We see improved cardiac benefit, and studies show that cardiovascular or heart disease risk have some flaws in them that way. The other side of the coin is that other doctors are saying no, it's unproven. It's just a profitable market. Their doctors are using testosterone to increase their funds, their money. It's not, the specifics are non-specific, and they don't foster disease states, but yet there is data to show it does. And they say there's no consistent relation between testosterone levels and symptoms of those associated with low testosterone. What I want you to see is that there actually significantly is. If you have a low testosterone, in 2011, they published in the Aging Male, they showed that when your testosterone drops, you will see increased hypertension and increased heart disease. When your testosterone drops, we see increased mortality. We see that in 2 studies, in the heart and circulation. When you actually have a low testosterone, it's associated with memory loss and Alzheimer's dementia. That's significant. And 2 studies have shown that significantly, if we look back in time. Now, the general principles of hormone treatment are this. Patients seem to feel the very best when the hormones are centered around the normal median, or this. If you have a range of high and low, most people feel good when those hormones are somewhere between 50 and 75% normal. And so that's usually what we do when we treat this. Now, the problem, and the reason this is so significant, is that the labs change the normal value for testosterone. Today, if you go to the lab and you get a testosterone level drawn, they will say normal is 264 in total testosterone at the bottom end, and high is 916. So the lab median here is 590. However, arbitrarily, out of the blue, July 17, 2017, they changed the median lab because what they do is every 10 years, they take a general population set, and they cut off the bottom 10% and the top 10%, and they use a bell curve, and they say, well, we should shift this. And this is what they did. They found that the average testosterone in 2017 had shifted from where the normal was 348 at the bottom and 1,000 or 1,100 at the top end, with a median of 772. They suddenly changed the median, and now by 200 points, we've suddenly dropped testosterone as a normal value. And most doctors use this range here now, not realizing that the range has dropped. Most of my patients who come and see me, they feel symptomatic if their testosterone is lower than 450, and that's a significant issue. But yet it says normal by today's lab standards, and that it really isn't, according to what I've done over the last 25 years and the patients I've seen. Now, let me just show you what testosterone does. Testosterone converts into 3 different hormones. It acts in 3 different hormones. Part of testosterone may be converted to estrogen. And this helps with bone absorption. It helps, the higher you have estrogen, it lowers your HDL in men. And the more estradiol you have in men, you'll see brain effects and breast effects. You'll see breast growth. You'll see a lowering of the good cholesterol. There is some important estradiol that you need to have because it does help your brain. It helps your liver. It helps the testes. There's some effects that the estrogen has on men, but too much of it will stimulate osteoporosis and atherosclerosis or plaque in the arteries. Testosterone itself stimulates muscle mass, bone formation, and the formation of sperm, and drives sexual desire. And then the DHT, which is a byproduct of testosterone use, helps the skin, the liver, and the prostate, and it stimulates facial hair growth, body hair, prostate growth, and acne. And so these are the things that you'll see testosterone assisting with or causing to have happen. Now, the thing is, testosterone can't be stored. There's no storage ability of testosterone, and testosterone clears you out of your system in 17 hours. The problem is that in men, the testes are constantly making testosterone, and then it clears out of the system. So you've got to have it available all the time. And 2% of the testosterone is bioavailable because it's weakly bound to albumin, and the 54%. Pardon me, the bioavailable form is bound to albumin and sex hormone binding globulin. That which is bound to albumin is about 54%, and it's easily accessible. 44% of it is bound to sex hormone binding globulin, which is it's basically a transport molecule through the blood. And so even though our body's making testosterone, more than half of it isn't really quickly available to us. And if it's not being used, or if hormones change, raising albumin or sex hormone binding globulin, then less testosterone is available to the man. And we'll talk about that. So sex hormone binding globulin is a transport molecule for testosterone. It transports the testosterone, and things that raise the sex hormone binding globulin are metformin, berberine, and exercise. Things that lower sex hormone binding globulin is insulin, obesity, elevated blood sugar, and hypothyroidism. So these are factors that play a role in our accessibility to the testosterone. Now, third player is this: stress. Stress plays a role in what testosterone does, and the reason is that stress stimulates cortisol. So this is a low cortisol level, and this is a high cortisol level, and these are men who did a competition, and the men who actually were successful in their competition, and they won the competition, they had their cortisol stayed low and their testosterone went up. Those who lost the competition, when they tested them, their testosterone dropped with the high cortisol. So as their cortisol was high, they actually had their testosterone fall. And when their cortisol was low, their testosterone would rise. And so if you're under stress, you will see a significant drop in your testosterone. And that's one of the reasons that I see in my office is chronic stress plays a significant role in the amount or availability of your testosterone being present. Any questions about any of that thus far? All right. I won't dive into all that part of the study, but I just wanted you to know that's the case. So chronic stress is really bad for your testosterone, and that's the key. So you've got to be able to eliminate that stress. You've seen this slide before, I think, if you've been in my Keto Clan group. Knowledge is the process of piling up facts, but wisdom lies in simplification of those facts. Now, in the male, this is how the normal body produces testosterone. Your hypothalamus produces gonadotropin releasing hormone that stimulates the anterior pituitary gland, which then releases hormones, luteinizing hormone and FSH. Luteinizing hormone is what drives the production of testosterone from the leading cells in the testes, and FSH stimulates the formation of sperm in the Sertoli cells of the testes. There are two types of cells, and we'll look at that a little closer. But the testosterone plays a role in muscle growth and sexual desire and those kind of things. This is actually a patient sandwich I took a picture of in the hospital. And now, when you look at this is ironic because it's named a patient sandwich because it's for the patients to eat in the hospital. But when I looked at this first, I went, "This is a sandwich made of patients," and to me, it was funny. And what they showed was that the degree to which you find this humorous is based on your testosterone level. The higher your testosterone goes up, the more you find irony like this humorous. My wife doesn't think it's funny. I thought it was hilarious. And so I have a higher testosterone than she does, and that's actually fascinating. So if you don't think ironic stuff is funny, you might have a lower testosterone. Now, there are two types of testosterone problems. There's primary hypogonadism and there's secondary hypogonadism. Primary hypogonadism is a poor production of the hormones at the either the testicles or the ovaries. Secondary hypogonadism is a poor production at the brain or pituitary gland. And I won't dive into this, but when your doctor is assessing your thyroid function or your testosterone function, he or she is going to be looking at where is the dysfunction at? Is there a problem with the way you're making it at the testicles, or is there a problem with the way you're making it at the brain and the pituitary gland? All right. That's just a little insight to know what the doctor might be calling your. If he says you have primary hypogonadism or you have secondary, that's what you're seeing. Now, the job of testosterone is to make hair and muscle strength and sexual desire and sperm. At that, when you have testosterone produced, it has a natural feedback mechanism to suppress further testosterone production when the level is correct. And inhibin is produced and stimulates a suppression of luteinizing hormone, follicle stimulating hormone, and testosterone also suppresses GnRH. So if your testosterone goes up to 800 or 900, you're going to have a negative effect on further production of hormones to stimulate to keep that level stable. Now, what's very interesting is as your insulin goes up, it has an inhibiting factor on luteinizing hormone. And as leptin drops or kisspeptin drops, you're going to see a drop or an inhibition of gonadotropin releasing hormone, which will affect the way the pituitary gland releases these two hormones, LH and FSH. So what essentially that means is that your insulin goes up, it releases calcitonin, it's gene-related protein or peptide, the CGRP, and those both have a negative effect on luteinizing hormone, which then suppresses the production of testosterone in men. It has an opposing effect, which we learned about last week, in women. But so if insulin goes up, it's going to make more testosterone in women. It's going to decrease testosterone in men. And as it decreases testosterone in men, insulin will also decrease adiponectin at the fat cells, and decreased adiponectin raises sex hormone binding globulin, and sex hormone binding globulin overbinds the testosterone and makes it not available to men. So so we see a lowering of testosterone and hypogonadism in men, if that makes sense. And so this is the hormone cascade that you see. Basically, high insulin and weight gain suppress testosterone in men, and that's what we see. If that makes sense, hopefully that answers your question. Or if you have questions, it's answering it. So age also plays a role with testosterone. You'll see that as your age goes up, your testosterone declines. As age goes up, you see a sex hormone binding globulin level go up as well. And your luteinizing hormone goes up as well. So this is happening. Now, this next slide shows that with age and with weight gain, a body mass index of over 30 is the red. They naturally already have a low testosterone. And as you get older, your testosterone gets lower. And the vice versa with the sex hormone binding globulin. This is the free testosterone. You'll see that being overweight lowers your testosterone by about 100 to 150 points. That's pretty significant. So if you can get the weight off, your testosterone will rise by almost 100 points. And that's what I see, and I've seen for years. Now, oops, run the wrong way. Okay. As I mentioned earlier, if I cut your calories down to less than 1,500 or 1,000 calories per day, within about 7 days, you will have a drop in testosterone by about 50 points or 50%. That happens in both men and women. That's significant. And the binding protein that holds onto the testosterone, called sex hormone binding globulin, it's doubled by calorie restriction. So that's something that's significant and something that you want to be aware of. And this is why I'm not a big proponent of lots of fasting. I'm a proponent of fasting. Fasting is helpful. But if you fast more than 2 or 3 times a month, or if you're doing intermittent fasting, prolonged, so let's say you fast for 16 or 18 hours and you're doing it every day for a month, within half that month, your testosterone will tank and your thyroid will tank at the same time. I have people that have done fasting programs and they've lost weight, but they come to me a year later going, Dr. I don't understand why I'm tired. My testosterone dropped and my thyroid dropped, and now I can't get it back up. And that's because if your calories are restricted, and it's really the protein, if you don't get enough protein, you will see your testosterone tank. Questions about that at all? Or that makes sense? Okay. Now, what are the symptoms of having low testosterone? In a man, it's your sex drive drops. You have difficulty achieving erection. You have significant loss of muscle mass. You have an increase in body fat. You're fatigued. You get dysthymic. Your mood goes to. You have frequent, continuous irritability or feelings of depression. You have a low seminal volume. Excuse me. You have hair loss, and you actually will see your testicles shrink. That's pretty significant. And for many men, that's embarrassing. So a lot of guys don't want to come talk to me about it because they don't feel comfortable with that. Excuse me, I'm losing my voice. All right. Symptoms of andropause goes on further. You'll see tiredness and loss of energy, depression, irritability, angry, bad temper, anxiety or nervousness, loss of memory, loss of libido, loss of erectile, you lose erectile function. You can be anemic. If your testosterone is low, you can be anemic if it's low for a period of time. I've got guys that have low testosterone for about 6 months and they are anemic. You will actually get, if I lower your testosterone low enough, you'll get hot flashes because your testosterone provides the availability of estrogen, and without the estrogen, you'll have hot flash. With guys that have prostate cancer, when they give them the hormones that suppress their testosterone, hot flashes is a major complication with that. You'll have a decreased intensity of your orgasm. You'll have backaches and joint pain. You lose your fitness capacity. You feel overstressed. You have decrease in job performance. You see bone loss. You actually will have brittle bones start to arise. Your cholesterol goes up, and you have osteopenia or osteoporosis. Bone, that's the same thing, bone loss there. Your confidence goes down, and you have increased fat in the hip region and around the abdomen and in the breasts. These are all significant, and I see a lot of these every day in my office because people have low testosterone. Now, what are the normal ranges of hormones that I would like to see in both men and women? DHEA is a stress hormone. It helps you handle stress and recover from it. As a male, you should see it around 275. That's the median range. A woman, it should be around 150, 180, 183. Total testosterone in a man should be 770 before 2017. I shoot for 770 in my office, but right now the median range is 690 if you use the current normal range, which I think is 100 points too low. And the median range for a woman is about 44. Most women I see in my office, they're lucky if they have a testosterone higher than 10. And that's significant. Free testosterone should be around 14 as a male. As a woman, it should be around 2 to 4. Most women I see, they don't even have any. You can't even measure it. It's not measurable. And men is usually down around 5. Dihydrotestosterone, which is a byproduct of testosterone, should be around 52-ish. Women should be around 15. And then sex hormone binding globulin, if we measure it, I don't measure it in everyone, but if I think there's a problem with your insulin level, and I think the sex hormone binding globulin is binding your testosterone, as a male, your sex hormone binding globulin should be less than 45, and the women should be less than 75. So those are just the normal ranges we were looking for. I don't necessarily use testosterone to sex hormone binding globulin ratio, but some doctors use it, and so these are some normal ranges we're shooting for if you're using these two ratios to look at your sex hormone binding globulin to total and free testosterone. All right, now 30 to 60% of men in their 70s are actually hypogonad is what we found in the 2009 aging male study. That's half the population gets a low testosterone when they get into their 70s. Half of healthy men between the ages of 50 and 70 have testosterone levels below the level of a low testosterone level in a man who's 20 to 40. Again, we see the significant decline in testosterone. And the Massachusetts male aging study has demonstrated a 30% over the last 30 years, has demonstrated a 48% fall in total testosterone and an 85% fall in free testosterone. So in 30 years, we've seen a 50% drop in testosterone in men generally. And that's significant. And if you know that testosterone, most of the men I see in my office will be symptomatic if that testosterone drops below 400 or 450. And half the patients we see their testosterones are in that range when they show up in my office. That's a big deal. Now, what about medicines? You come into my office and you may be on a diuretic or an ACE inhibitor or a beta blocker. They lower your testosterone. The statin drugs lower your testosterone. Antidepressants lower your testosterone. Chronic use of non-steroidal anti-inflammatories, the Motrins and the Advils, they do it. Antihistamines do it. Parkinson medicines do it. Proton pump inhibitors do it. Muscle relaxants do it. And chemotherapy does it. So a lot of times you may be on a chronic medication. You come into my office, and this may be part of the cause of your testosterone being low. How ironic is that? In my perspective, it's majorly ironic. So what I often use as a first step is first, I know that insulin plays one of the biggest roles. If I can fix your insulin and get your insulin down, I'll see 150 points of rise in your testosterone. So I will often use berberine or metformin. Metformin is the prescription. Berberine is the over-the-counter version. Berberine will, if you use it twice a day, we can get your testosterone come up by 100 to 200 points. I found a product that uses herbal components and added to it. It uses fenugreek. Fenugreek naturally raises testosterone, and it does so effectively. And if we combine berberine with fenugreek, we'll actually see improvement in blood sugar and an improvement in the testosterone. Alpha lipoic acid helps the absorption of fenugreek and berberine, so that's why we use it in that regard. But this is one of the products that I like to use in my office. It's over the counter. There's no prescription required for it, and it actually dramatically helps both blood sugar and testosterone as well. So we treat the insulin resistance first. We get your diet under control. We may need to add a supplement or a medication to get that insulin down and get the testosterone come up. Then we treat leptin resistance. Now, what's the driver behind leptin resistance? Well, it's fructose and alcohol. You'll notice that as your liver processes alcohol 100% in the liver, it processes 90% of fructose in the liver. And as fructose is being processed, it produces a hormone or a product called aldehyde and fructose 1P, and these drive leptin resistance. So if you're using a large amount of alcohol, if you're using a large amount of fruit or high fructose corn syrup, that's going to cause leptin resistance, which will also lower your testosterone. So we want to get rid of the leptin resistance. It's essential. Fructose is metabolized differently both in the liver and the brain. So this is where you'll see that glucose is ingested. This is the satiety center of the brain here. And the satiety center is stimulated by glucose. But you'll notice that if you eat fructose, there is no satiety center stimulation. The fructose is actually stimulated in the back of the brain. And this is why bears and humans, if you eat fruit, you gain weight because it actually stimulates more hunger later. So the more fruit you eat, the more hungry you will become. That's just important to know. You'll notice that that's how the bears gain the weight as they prepare for hibernation, is they eat a bunch of berries. And that's what drives that process. Now, so we treat the insulin. So we put them on a ketogenic or carnivorous diet. We lower their leptin resistance by cutting out their fruit and their alcohol. We improve adiponectin signaling. Adiponectin signaling is done by exercise. Exercise raises testosterone and allows for a rise in adiponectin. Mike and Mona they're bodybuilders. They're actually a real cool couple. I got a chance to meet them a number of years ago, and they've been a big proponents of ketogenic diets. That's why I put their pictures up there. Anyway, fourth step. So insulin gets lowered or improved. Leptin improves. Adiponectin improves, and then we want to lower cortisol. So we want to use tools at our hand to lower stress. Chronic stress, whether that be physical or emotional, we want to get rid of that. We want to make sure you're sleeping adequately. Get 7 or 8 hours of sleep, and your testosterone goes up naturally. If you have an untreated bacterial or fungal infection, it will raise your cortisol. I've seen some patients that had chronic sinusitis or chronic fungal infections, and if they're not treated, your blood sugar won't improve. Malnutrition, if you're not getting adequate protein, then you're not going to see a drop in cortisol. One of the side effects that we see with the use of GLP medications, and I use them in my office all the time. I use tirzepatide and semaglutide in my office. But the key here is to ensure that you're getting adequate protein. If you're not getting adequate protein, you fall into the malnutrition range, and your cortisol spikes, and your blood sugar goes up, and you start gaining weight. Psychological stress plays a huge role. Any of the forms of anxiety will raise the cortisol levels, and alcohol use, excessive use of alcohol, will actually drive that process. Any questions about stress there or cortisol rise? We got to get the cortisol to stabilize, otherwise you won't lose weight and your testosterone will stay low. All right. Fifth step, if we don't get the testosterone to come up naturally with these 4 steps here, and sometimes we don't, then you might consider adding exogenous testosterone, or that's testosterone from outside the body, using an injection or a cream. In the office, we'll use between 100 and 250 milligrams of testosterone, and that will raise your testosterone within 1 to 2 months. I'm sorry. A ketogenic diet will raise your testosterone by about 200 up to 250 points alone. If that doesn't do it, then we want to add cortisol or add testosterone supplementation. We don't want to do it, especially if the testosterone is less than 350. I used a lot of testosterone shots. I use testosterone cream in my office. A big deal. If I give you a shot, I can get your testosterone easily up to 770. And my goal for your testosterone is to be at a minimum of 600 or 700. That's what I would, because most people will feel better, they'll lose weight, they have energy, they're more likely to exercise, they do a lot better. Now, we do have to be wary that if you have active prostate cancer, we don't want to give you testosterone because testosterone stimulates active prostate cancer. If you have a PSA over 4, before we add testosterone, we want to make sure we check you out. If you make sure you don't have cancer. Severe LUTS means urinary tract infection, urinary retention, or slow urine stream. If you have breast cancer or untreated erythrocytosis, which is untreated high red cells, then that we don't want to use testosterone with you in those cases. So, if you have prostate cancer that's been treated and you're 10 years out and your testosterone, your PSA is normal, we could consider adding testosterone back on board, which we do with some patients. Questions about that? That's so now there's lots of products. There's androgel, there's different forms of topical testosterone creams. Then there's injectables. That's what the testosterone cypionate is. We use a weekly injection. I do testosterone pellets in my office, and we'll apply between 4 and 10, or pardon me, 4 and usually 9 testosterone shots, and those are very effective. And the benefit of pellets is that you put them in every 6 months, and you don't have to worry about it. With a shot, you have to get a shot weekly. With testosterone pellets in women will last about 3 months. In men, they last about 6 months. For real severe cases, if you can't get the testosterone back up, we can use Clomid, but we don't want to use Clomid at ages less than 40 years old. Otherwise, it stops. It causes some other major issues. Now, if you're wanting to have children, and you'll say you got married in your 30s and you haven't had children yet, but you have low testosterone, giving you oral injectable or topical testosterone will have an effect, can have a permanent effect on your ability to produce sperm. So we don't want to give testosterone to someone who still wants to conceive. We want to use natural methods to raise the testosterone if we can, because you can have a decreased spermatogenesis using testosterone in a shot or a cream. That is one of the things that happens. As you can see, a suppression of the feedback mechanism, which lowers the sperm count. All right. What we've shown is that treatment with testosterone, either topically or injectable, increases your insulin sensitivity by up to 32%. It's fantastic. It works really well. Now, so step 1 through 5, we've lowered the insulin, we've lowered the leptin, we've increased the sensitivity to leptin, we've increased the adiponectin signaling, we've stabilized your cortisol. We may have considered giving you oral or injectable testosterone. Now, the last step in the process, if it's not working, is to get your gut balanced. We know that if we put you on a ketogenic diet, we stabilize your gut flora, and your capacity to absorb testosterone or make testosterone actually gets better. If we decrease the growth of bad bacteria, it decreases the inflammation. That chronic inflammation has a suppressive effect on testosterone by raising cortisol, by balancing the 3 or 4 hormones in the gut that play a significant role with insulin resistance. And we can use different probiotics that are low or mid strength. And I won't dive into that because that's a whole other topic in itself. But one of the things you need to know is that if you follow a ketogenic diet for 2 to 6 months, you will actually naturally stabilize your gut flora and see dramatic improvement in your cortisol and in your testosterone. All right. As you can see, the starches are the weapons of mass destruction in men and lowering the testosterone. If we cut the starches out, you actually see improvement in your testosterone. The one good thing about being a cowboy is you get lots of steaks and you don't have time for golf or play want to play golf. Anyway, that's the end. Questions about the testosterone levels? I must be so good that we actually answered all your questions, or you guys just are asleep. One of the two. Maybe you need testosterone. I don't know. Any questions about testosterone? David, question you had?
Yeah. How does this affect prostate enlargement, or how does supplementation of testosterone
So
earlier end up with enlarged prostate later?
So what we've found is, and what I've seen in my clinic is that the enlarged prostate is because your estrogen progesterone ratio is off. You are estrogen dominant. When you have a high estrogen and your testosterone is lower, you're likely to form enlargement of the prostate. Testosterone doesn't cause the prostate cells to enlarge. Now, testosterone will stimulate growth of a cancer cell if a prostate cancer is present, but it won't enlarge the prostate. Most doctors thought it did years ago, but we've been wrong in that, and the studies show that that's not the case. What's the case is that if your estrogen to progesterone ratio is off, so if your estrogen is way high because you are eating a lot of xenoestrogens or you're using a lot of soy products or things like that, then we will see that change. So we want to make sure your estrogen stays normal. If your estrogen is going up, then you may see testosterone, or you may see prostate enlargement. Now, years ago, when docs were giving huge amounts of testosterone to men, we used to give testosterone shots every month, and we gave 2 to 4 times the normal amount of a testosterone shot. And when you give a giant bolus of testosterone at the front end of the first 2 weeks, that testosterone will convert into estrogen and will raise the estrogen. So you may see prostate enlargement from these older versions of big, huge testosterone doses. I use weekly low doses, so we don't see a rise in estrogen. That's one of the things that I've found keeps the prostate from getting enlarged. Good question, though. Thank you for asking that one. Any other questions? Well, hopefully that answered them all. Thanks for coming and thanks for joining on. I'll let's see. A few people told me they couldn't make it tonight because they had other conflicts, and so I'm going to record this and then post it on the website here later sometime this week. But thanks for coming. Any other questions before I hang up or before we close?
One question quickly. I had done a panel of hormones probably, I think, like in the last month. We've upped my progesterone, and so how soon should I do lab work again to evaluate?
So usually it takes about 2 to 3 months to level off progesterone, estrogen, and testosterone. So routinely, I will, if I have you on hormones, I'm probably going to want to check your hormones every 3 months to make sure those levels, every 3. So your hormones are stable. That's a great question, Stacy. Thank you.
Okay. All right. Cool. Thank you.
You're welcome. Any other questions? All right, guys. Well, thanks for joining on. Have a great Thursday. And if you need testosterone, come chat and we'll get you set up. Pleasure to see you. You guys have a great night, and we'll talk to you soon.
Thanks.
You're welcome. Good night.